So, can I go to the last presenter today? And this is Heather Shearer, and she's going to be talking to us about aligning national and local approaches to improve quality and efficiency. Heather, why don't you tell us a little bit about yourself first?
Thanks. Good morning. I'm Heather Shearer. I'm the Head of Quality Improvement in NHS Fife, which is just geographically south of NHS Tayside, who we've heard from so far. What I'm going to be doing is sharing with you some of the nuts and bolts of our early stages in Fife of developing our Quality Improvement Hub and how we see that aligning with the National Quality Improvement Hub. And I'm going to do that by particularly focusing on a number of different issues, shared issues locally and nationally. I'd like to thank the co-authors that have helped put this presentation together, both from NHS Fife and from Healthcare Improvement Scotland, and also acknowledge our Chief Executive in NHS Fife, John Wilson, who's letting me share sort of fairly warts and all data, which isn't always easy for people. So about this time last year in Fife, we weren't in a bit of a pickle. We weren't in a good place. We weren't happy with the system level of care that we were giving to our patients. If you look at the data on the left-hand side as you look at the slide, that's our access measure. So that's the percentage of patients who are being seen by our emergency access team within 4 hours. We're aiming for 98%. That graph goes back to 2010. You can see we'd pretty much never met it. Not a great start, and in fact, we looked like we were heading in the wrong direction entirely. We did relocate the hospital, but nonetheless, we weren't in a great place, and we were therefore under the spotlight, both from ourselves and also from others, quite rightly. And we had a £19 million financial gap that we had to meet. We decided, much as Jerry and Carrie have talked about, that for us, and in the context of Scotland, quality without efficiency is unsustainable and efficiency without quality is unthinkable. Now, we haven't made that mantra up. I was trying to find out who to attribute it to, and I can't find the original author of that. But for us in Fife, practically how we are interpreting that is combining two approaches: the quality improvement methodology that pervades this conference and a programme management office approach. And what we're trying to do is combine the creative, positive energy that comes about from using exciting quality improvement methods with the responsible, rigorous, efficient use of resources that we need to do for our taxpayers' money. This schematic in the bottom right shows how we conceptualise those two parts of our system. So we have the PMO, which contains a large range of projects all about delivering our most effective use of resources. And within that, we are identifying some particular projects that have specific QI input. We also, in our schematic, have an overlap that's outside of that PMO. In reality, at the moment, all of our limited resources focused on delivering things that are part of our efficiency and quality drive together. But we do hope in the future to have the kind of more creative opportunity to do innovative pieces of work that might not be part of the PMO system. So we were in a bit of a pickle. We had a look at what we had going on in our organisation, and this is my way of representing what we looked at and we discovered was we had a range of different teams and individuals, some small, some large, working on quality improvement problems, working very hard, doing their very best, but we often found that they weren't working together. We had different teams working on different problems. We would find that two different teams were working on the same issue or on the same programme, and they may not know that the other area is working on that, and they certainly weren't doing it collectively. We also found examples where one particular clinical team had asked for quality improvement support and had got input from a number of these different teams, but the different teams didn't know what input had been given, and effectively we're leaving the busiest part of the organisation to somehow make sense of all this well-meaning support. So we thought, okay, what we think that's doing, we can see that in our outcomes, because what we see are some really great examples of quality service, some pockets of fantastic service in Fife. But as I've just shared with you, when you look at one of our system level measures of quality, and it's only one, but one of them, we weren't seeing that system level achievement that we need to. So we decided to create our own local NHS Fife QI hub, getting those people that we've just talked about around the table. It's not about creating a new empire, it's not about creating a new team, it's really about strengthening the bonds between the existing skills that we have within our organisation. And between us, we've got quality improvement expertise, we've got some people with fantastic organisational development skills, analysis, information analysis skills, and we've been creating a physical space for QI work. This is our physical space. It's not very flashy. We're squatting in an old theatre. In fact, we really are squatting because I think we're supposed to have moved out, but we're operating on the basis that occupation is 9/10 of the law. What you see is we've stuck up some large boards around the wall. We've got 5 major work streams at the moment. Each work stream owns its own board and can put up things on it that is telling their story about how they're progressing. We use lots of current data for improvement on those boards, and we're pretty light on the laminate. I don't know what you find, but we find once you've laminated something, nobody wants to change it or take it down or move it. They might stick something on top of it, but no one will ever own up to doing that. So actually we've been very light on the laminate. It's printed bits of A4 paper up on the board and then take them down, write on them, annotate on them, whatever you need to do when you're doing your QI work. We encourage working use of the boards. The picture in the top right-hand side was us doing the mapping that I've just talked about. So that's actively using the boards to say, well, who have we got working on what where? Gosh, isn't that surprising? What we're trying to do is, as I've said, is combine the improvement methodologies with the PMO type methods. What we're aiming to do, and we've made some progress, but we haven't cracked it at all, is to have very light documentation, and the front end of all of our work with clinical teams is the QI language. It's not the PMO language. That happens in the background. But we're trying to keep things paper light. So this, for example, is a charter on a page that we're using. We've been learning from Cliff and Jane Norman from the States on this. In particular, you'll recognise the 3 questions from the model for improvement, and that is a single page that describes the whole project, key objectives, measures, and tests for change. We supplement that with single-page summaries of those small tests for change. What we've found, and I wonder if the same is true for some of you, is that we're getting better at doing the small tests of change, but actually capturing the learning from that is pretty tricky. This is an example when we were looking at allied health professional input into the acute admissions units at weekends, and we did a rapid series of tests on consecutive weekends, which was telling us very quickly about the types of AHP experience that would make the difference, things about how to make referrals to those, where they were going to be situated, could they flow between different settings, and that really made a difference to how we were able to build the business case for making that a sustainable change. It wasn't a new idea. People had been talking about it for years, but I think the difference was that we'd gone in at the business case level before, trying to make a business case that required investment, on the hunch, if you like, that it would make a difference. But by doing the rapid testing, we were able to supplement that with some really good evidence about the change that it might make. I've said that what we're doing is trying to bring together existing teams with existing sets of skills and harness those. How we're trying to do that is using and adapting Deming's system of profound knowledge, because we needed to find a way of bringing together all these different skill sets. There's too much on this slide for you to read. Obviously, it'll be in the pack, but I'm trying to signal to you that we're developing a series of standard diagnostic and data gathering questions that we as a QI hub will apply to every new problem. Some of them are our own questions, some of them we've begged, borrowed and stole from other people. But we're trying to use this as an overarching framework to say, do we understand what's going on in the system? you who are really good at the human side of change, what do you have to offer on this problem? How do we analyse the data that's coming into us and bringing that all into a shared diagnosis? So that's a very brief introduction to what we've started to do in Fife. Nationally in Scotland, you've already heard a lot about what we're doing nationally in Scotland, and you will continue to do so over the next couple of days. We've developed a national QI hub, the purpose of which is to increase the capacity and the capability in QI methodologies across Scotland, or a bit more pithily, to be the champions for quality improvement. The National QI Hub was launched in May 2010. It's a partnership between 5 national bodies: our Improvement and Scrutiny body, our Education body, our body responsible for data and information analysis, Public Health, and our Government Quality and Efficiency team. It has a small core team, and each partnership identifies resources for specific work streams. This summarises the purpose and the current work streams, and I'm going to pick out through the next couple of points issues around spread and sustainability and capacity and capability from this broader representation of the work that nationally we're doing. So some of the pieces of work that the National QI Hub have been involved with, they've been working with designing and testing innovative approaches to improvement in a number of different clinical settings: older people in acute care, diabetic patients in acute care, and they've been working on assessing the needs for educational tools to support QI. This describes the early results from the pilot wards involved in the diabetic or the Think Glucose work. And on these wards, through implementing some fairly simple ideas, stickers, algorithms, charts, boxes, making things easy to be in the right place at the right time, insulin errors are reducing by 50%, the number of hypoglycemic episodes have reduced, and of that smaller number, an increasing proportion are appropriately managed, and the mean length of stay for these patients has reduced by 2 days. So some really encouraging early results from the pilot work. However, there's still work to be done from a national QI hub perspective and obviously from local perspectives. One of the great challenges is the clarity of role and remit. So what should be done at a national level, what should be done at a local level? What support is required across Scotland? What needs to be targeted very locally? The National QI Hub faces capacity challenges, and one of their challenges is responding, or having the ability to respond to when people like me from boards say, can we have some help with this? And that becomes a vicious or a virtuous cycle in terms of how we interface with a national body, in terms of the response, the ability of that body to respond to us when we ask for help. Either then strengthens our relationship, or we think, oh, well, they weren't able to help us, we'll go somewhere else this time. So that's a real challenge for the National QI Hub. Carrie and Jerry have talked about collaborative working, but between organisations that can be very difficult. Making sure you have the right people around the table with the authority to sign up their organisations, resources to support a particular work stream, being able to negotiate all the different governance arrangements within those bodies. And another challenge is making sure that the National QI Hub is kind of up there on the horizon scanning, so that that's the body that we become confident that we can go to and say what's going on, and that they will have a really good sense of what's happening in the horizon in Scotland and further afield in relation to quality improvement. So just to focus a little bit on building capability and using that as an example of how we can align local work with national work. In Scotland, we have got a national quality improvement curriculum which has been developed, which describes different levels of QI expertise, the level that you might need for all staff, you might expect all staff to have, and levels that you would expect lead quality improvement practitioners to have. Now we've got that, we can start to understand what our capability is within boards and nationally. So in Fife, for example, we had a look at all of our graduates from the last sort of 3 years from quality improvement programs that we ran. So they might be programs on the model for improvement, lean programs, patient safety sessions. And we've got about 650 people within our board who've been through those programs. And I reckon, and this is a judgment and it's art, not science, but I reckon from that we've probably got about 15 people in our board working at a lead practitioner level, which is 0.1% of our staff. Nationally, the QI Hub looked at some of the national programs that were run around quality improvement, and they've counted about 500 graduates from those programs who are probably operating at practitioner stroke lead level. They've also conducted a survey of boards, asking boards to share with them their level of capability that they have, and have discovered a huge range. So from boards reporting no one with quality improvement knowledge up to over 1,000. Now our boards do vary in size, but that's quite a significant variation. So by looking at these things locally and nationally, we're starting to learn together about building capability. And so what are we learning? We're learning that measuring capability is tricky. We tend to go to self-assessment. It's relatively cheap to do. We don't necessarily want to be examining or assessing quality improvement knowledge. But that does mean that we suffer from the kind of conscious incompetence problem. I know from some of the best QI people I know would be very cautious in rating themselves or very on a self-assessment scale, partly because the more you learn about quality improvement, the more you know you don't know. Every time I come to one of these conferences, I realise how much less I know than I did last year. And in contrast, I know of some people who've maybe had one session on PDSAs and think they've cracked it and think they're dead simple and they've got it, and they would be very confident in their assessments of QI. So relying on self-assessment is tricky. The question about absolute numbers versus a one-step away philosophy. We're starting to get a sense of how many people have got certain levels of skill, but then a key question is, well, where are they situated? If your health system is looking after community and acute systems, but all of your QI practitioners are located in one part of that system, how does the other part of your system access them? So the notion that we would like to get to a point where everyone is only one step away from someone with some really high quality improvement understanding. And a point to pick up that we are learning about is the challenge of the words capability and capacity. We tend to put them together really quickly. We say it really quickly, building capability and capacity. But what do we actually mean? And I think what we tend to be, by doing that, we're actually not doing ourselves any favours, because they're different things that require different tactics. When we're talking about building capability, we tend to be talking about designing learning experiences for people. When we're talking about capacity, we're talking about how do we then enable those people who've had those learning experiences to use that. We've discovered we've got tons of people who've been on courses in QI or various sorts of QI who then go back to their day job and don't really have the opportunity to use it. They're back busy firefighting. What a waste of that resource. So it's different tactics for releasing that capacity. We need to get into job planning, we need to get in redesigning people's roles so that they have time to apply their new skills. Looking at the quality and efficiency questions, I've already alluded to how in Fife we're trying to combine those two things. Just to give you some further detail on that, our Programme Management Office Manager is a core member of our QI Hub team, and in fact is currently leading our scheduled care workstream, which tells you how core the PMO is within our QI Hub. We delivered the 19 million savings. It's probably in our 5% rather than our 95%. But we are much better able now to understand how quality improvement has contributed to that saving. It didn't deliver all of it, by any means, but we can now begin to say that piece of QI has related to that efficiency gain in a way that we haven't been able to previously. We haven't got it right. Our documentation still needs improvement. We've still got duplication between improvement charters and programme management project initiation documents. So there's lots still to be done, but that's our early experiences so far. Nationally, we can see that within the performance management framework that happens at government level, increasingly quality improvement is being encouraged and supported as a method for achieving that performance that we are expected to achieve, which is a really refreshing environment to work in, I think. And within that team, they've begun mapping the stages of an improvement journey to some of the efficiency and productivity portfolio office functions. So when that's completed, that will help us to map between quality improvement approaches and the efficiency in a very practical, pragmatic, tools-related way. So where are we now? And this is where it's not shiny data. This is up to the end of March, so it's very current data in Fife. What you can see is that we did actually make some improvement. We had, for the first time, we had a period where we did achieve the 98% target. We haven't managed to sustain that over the winter months. I have to be honest and say lots of other places have that problem too. So we feel that we've got better, we're learning, we think our systems are more reliable in that they can deal with the day-to-day variation much more successfully than we were able to before when we weren't achieving that standard at all. But when we have a special cause, when we experience a curveball, we still struggle to manage in those circumstances. So for us, sustainability is a challenge, and this is where we look to the National QI Hub for assistance. And one of their work streams is sustainability. So we're hoping that the work they're doing, looking at the evidence base, looking at frameworks, developing educational resources to support us in the sustainability question, will be a really nice example of where a national body can do some of that work, and then any number of local quality improvement teams can access that and build on that and apply that in our local settings. I don't know how you feel at your workplace, but we sometimes feel a bit like this. You know, when those tennis ball machines just keep throwing the tennis balls across the net at you. The plethora of initiatives that it feels like we receive over our desks on a day-to-day basis often feel overwhelming. And within boards, we tend to have only a relatively few number of people who are trying to hit back all those tennis balls, and clearly a few get missed. They're all initiatives that are important and well-intentioned, but one of the things that we look to the QI Hub to help us with, the National QI Hub, is to help in that rationalisation of some of those. And indeed they're doing that by creating this website, which will become a one-stop shop, if you like, for quality improvement in Scotland. So it should be the place that all of us in Scotland can go to say, well, what is going on? This is a run chart showing how that website is being used. So that's unique user visits up until the early part of March this year. And a really useful piece of work that's happening at the moment is that on that website they're creating a calendar of all the events that are happening in Scotland. It's a dead simple idea, but we find in a board that we get a whole bunch of events and they're on the same days, you know, primary care and mental health event on the same day, and you can't send the right people to the right event when it's clashing. But by putting this on the website, it will make it very transparent, and we hope that will be the first step in making a problem visible that we can then start to resolve across Scotland. There are still many debates. We know experience and evidence suggests that if we take a sort of single overarching methodology to quality improvement, we're more likely to achieve that system level success that we're looking for, rather than the pockets of innovation that we so often see. But that can be pretty tricky. You wouldn't necessarily use the same nail for every job, and we're finding that this approach can alienate some people within your resource who've got fantastic skills, but it's not badged under the new language, and they feel rather left out, and then either you're not using them or you're struggling with some of that internal politics. And, you know, dare to say it, but there's a bit of a emperor's new clothes about some of this. I'm sure some of you experience that in your clinical and working lives. Is there anything new in what we're trying to do here? Which is why in Fife and with the national body, you'll see that what we've been trying to strengthen are the links between existing teams and bodies, rather than creating new structures and adding on to our infrastructure. So in conclusion, where do I think we've got to? Well, you remember my sort of slightly weird dots and circles. I think this is where we've been, and arguably we're probably maybe there now. So we're still very much on a journey locally and nationally. We've perhaps got closer to having a number of different specialists working on the same problems at the same time, but we haven't got everyone there, and we've still got a long way to go. So thank you for your time.
Heather, thank you very much. I guess no one in the audience would recognise that problem of having all those different initiatives or functions that are separate or competitive or duplicative or all of that at the same time. We've only got a little bit of time for some questions or comments from our Twitter feed.
We've got lots of questions about your talk, actually. The first question I'd like to ask, are clinically active co-workers, and he's mentioned doctors as an example, but I'm sure there's lots of others we could talk about, are they really an active part of the QI team? Can they really be?
Can they really be? Well, in the detail of our programme, so within each of the 5 major work streams, we have role sponsors and we have clinical leads for each of those programmes who are currently active clinical leaders who have a particular responsibility around a work stream. And then within those programmes we have project teams which contain whoever that project thinks are the right people to be involved with. So they do contain frontline clinicians along with support from other parts of the organisation.
But embedded in that question is this whole issue of are the doctors involved either in a leadership or operational role effectively?
Well, honestly, I would say yes in some cases and no in others.
Okay, thank you. Next question.
Another question is, how and by whom are the individuals within the QI hub managed and coordinated at Fife and nationwide?
Well, within the Fife QI hub, at the moment, the bulk of the people in our QI hub remain within their existing management structures. As I was saying, we're not trying to create a new part of our organisation. It's about strengthening how we work together. So how we work with that is by working with the management leads and the executive leads for those different functional areas, and negotiating people's time, how much they can input into the QI hub, recognising the very real skills that different teams bring, and then trying to harness those through that shared diagnostic process that I talked about.
Okay. Any more questions from the...
There are some more.
There are some more. Time for one more from the Twitter feed, and then we'll see if there are any from the audience.
I think you partly answered this as well, but someone has asked what criteria can be appropriate for prioritising allocation of demand for help from the QI hub.
Well, I can talk about that more for Fife than nationally. Within Fife at the moment we have 5 major work streams which are our priority areas. So we're trying to focus our QI input and support on those particular priorities for the organisation to help deliver that system level change that we need to in both emergency access and scheduled care, mental health, pharmacy and older people. We have a system which I didn't share with you. We're developing a process for receiving new requests for input, managing that and prioritising that. I have a flowchart somewhere which I could share with people, which is in development about how we go about doing that for new pieces of work.
Okay, thank you. Any other questions from the audience for Heather on this? I just have one while people are thinking. If this works, how will you know? What does success look like?
Success for us looks like better system-level improvements. So we've got we can identify some really great examples of innovative care in Fife, and there are posters downstairs sharing some of that. The challenge for us is making sure that we join that up to deliver that reliable care every time for every patient who's turning up on our emergency care or who's accessing our older people service. So for us, success will look like more sustained improvement in those system-level type measures.
Okay. Any final questions or comments for any members, any of our speakers today, for Jerry, for Carrie, and for Heather? If there are not, then we're going to draw this session to a close. I'd like you not only to thank all of our speakers, but also to thank our Twitter team here who've kept us engaged. And so a big round of applause for all of our speakers, and enjoy the rest of the forum. Thank you very much. Lunch is now ready.